Hello everyone, my name is Eileen Riggin. I'm the CCO at Examine, and it's my pleasure to welcome you to the 5th webinar in our male fertility series. So these will take place on a monthly basis, and we're joined each month by an expert in their field of fertility treatments or therapies. The event's open to all, and we have a wide range of participants joining us from HCPs, urologists, gynecologists, reflexologists, nutritionists, as well as the men, couples and individuals who are all on their own fertility journey. So you're very welcome to join us today, and I would now like to introduce you to our speakers. So our chair, Professor Sheena Lewis, is the founder and CEO of Examine and an honorary professor of Queen's University Belfast, where for the past 25 years she's dedicated her research into novel tests for male infertility. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers as well as numerous book chapters and reviews, and has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of the European Society of Human Reproduction and Embryology, executive member of the British Fertility Society, and was a founder member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examine, where it markets the exact range of male fertility tests powered by sperm comet technology, which is now the market leader for sperm DNA damage testing in the UK and Ireland. We're delighted also to have join us this evening Mr. Jonathan Ramsay, formerly consultant urologist at the Hammersmith Hospital and Imperial College, where he practices in London at the Lister Fertility Clinic, the Beaconsfield Fertility Clinic, and the Agora Fertility Clinic in West Sussex. Mr. Ramsay is a urologist specialist specialising exclusively in the treatment of male fertility. And although each couple's journey may seem similar, his investigations can lead to an understanding and diagnosis, and thus a much more rational and sensitive approach to their management. So we'd like to thank Mr. Ramsay for joining us this evening, and we look forward to the session ahead. Before I hand over to our speakers, I just want to run through some housekeeping with you. So I'll hand over shortly to Sheena for an introduction, and then hand over to Mr. Ramsay for the main event. And then we'll close the session for the last 10 to 15 minutes with questions from yourselves. So please do pose your questions through the Q&A function. Don't use the chat function. We'll reserve that if you have any technical difficulties, and we'll do our best to help you. But please use the Q&A to ask any questions. And then you'll also have the opportunity to rate the questions, and Professor Lewis will then share the questions during the Q&A session. Attendees will be muted throughout, and videos are enabled only for our speakers. And also all the events are recorded in the series, so you can see all the past events as well on the Examine website if you go to our events page, and be able to watch all of the sessions to date. So allow us about 24 hours to get the recordings online. And in addition, 1 CPD point will be awarded for attendees for the 1 hour event, and we'll circulate the certificates shortly after the session as well. So without further ado, I will now hand over to our chair, Professor Lewis, to start the session.
Good evening, everyone, and thank you very much for taking time to spend with us this evening. It's awful that you've had to drag yourselves away from the last few days of the Olympics. I'm sure, like me, you've been hooked on them, and as equestrian sport is one of my great pastimes, I must say I was very proud of the UK team yesterday when they brought home a few medals. So for the next hour, we're going to talk about my favourite subject, and that is male infertility. And tonight we have an absolutely fantastic speaker, and he and I sing very much from the same hymn sheet, where we think an awful lot more ought to be done for men than is currently being done. Before we talk about that, I'd just like to give you a tiny bit of history about our company. Yes, I will, whenever that moves to the next slide. Yeah. So our vision is to raise the awareness of male infertility, because really, even in these days, there is very little known about it. We want to provide men with knowledge and advanced testing, which they're not getting presently, And we want to demonstrate that optimizing sperm health and improving the quality of sperm prior to treatment will improve fertility outcomes. We know we've had the semen analysis and nothing but the semen analysis for many, many, many years. And although that's very important, it's the gold standard. We don't doubt that, we don't question that. There are many other tests that we really need to take which show us more about the sperm quality rather than just the sperm quantity. We set up in 2010 as a company from the university, and it really came about because people were asking me, could they have the tests that we had published in our research? And at first I thought, oh, what, dear, that's a silly idea. I'm just a professor in the university. I don't really want anything to do with the commercial scene. But as time went on, we realized that this was something, number one, that we ought to do, and number two, that we could do. And so we set up a company through the university and brought our first customers on board. The first ones came from Ireland, and then we opened up throughout the UK. As the years have gone on, we have attained a CE mark. Then we got the ISO 9001. New international customers, and we expanded our lab. Then again, we rebranded the company because we were called Sperm Comet, and we didn't think that was the most sweet name for us. So we called ourselves Examine, which is really that we examine men, and the whole company is devoted to looking at men and their health. Very recently, we got the ISO 13485, which those of you who are involved in the technical aspects of things will know that that is a stamp of honor, in the sense that it shows that it's a high quality test, very reproducible and worthy of the name. Well, why would you come to Examine? Because we're not the only test on the market, and we would be the first to say that. And the reason why we think you should come to look at our tests is because they can diagnose male infertility more accurately than a semen analysis. They can predict the likelihood of fertility treatment being successful. They're based on years and years of non-commercial research. And we're told that we have excellent customer service. And those of you who have already worked with us in the past, I hope that you will agree that that's the case. The Comet assay itself is unique in that there are 3 different parameters. We tell you the average damage across the sample. We tell you the proportion of sperm with good quality DNA and the proportion of sperm with poor quality DNA. And each of these parameters have different relationships to success in IVF. So really, there's nothing more to say about that you can't see here. We've got lots of publications to back up what we're saying. We think that exact tests allow men to take back their control. And that's something which we feel is very important, because down through the years of my career, I've had so many men talking to me and saying that they feel emasculated. They feel almost ostracized. They don't feel that anyone is considering them as people. And we want them to become equal players in their journey so that they will get better success. The other reason is because men often lose interest. If they have a failure and things haven't gone well and they haven't had a good experience at their fertility clinic, they don't want to continue for another cycle, whereas perhaps their partner does. And by actually engaging with men and talking to them and supporting them, we believe that we are doing a very useful, performing a useful role. A couple of things I'd like to tell you about sperm DNA testing, which I'm very proud of, is the fact that we are now in a couple of international guidelines. The European guidelines for sexual and reproductive health in 2020 have said that more complex testing than semen analysis may be required, particularly for unexplained infertility or for those who have experienced pregnancy failure. Also, the ESHRE guidelines for recurrent pregnancy loss, of which I was a co-author, we have brought in for the very first time in European guidelines, we have brought in the man into the equation. And I think that's very important for both the male and female partners. And the new WHO manual is coming out. In fact, it was just launched last week. And in it, it also says that the evaluation of DNA fragmentation could constitute an important addition in the workup of the male. Now, that has taken 25 years to get to this stage. So we are very proud of the fact that our persistence and research has come to this point. Tonight, we have Mr. Jonathan Ramsay man of great repute and knowledge, talking to us about the ideal urological workup of the male who's experiencing infertility. I have the pleasure of working with Mr. Ramsay for a number of years now, and when we hear him lecturing, as he's going to tonight, you will find that it is so simple, so succinct, so understandable, so memorable that patients and colleagues alike can learn very, very quickly from what he's going to say to us. A couple of years ago, the BBC picked up on something that the Human Fertilization and Embryology Authority had pointed out, that male infertility is now considered the leading cause of a couple's problems. Now, we had known for a very long time that it was a huge problem, but to say that it's actually the leading cause, here we are 3 years on, what have we done about it? Very little, sadly. We're still depending on ICSI, a random use of a sperm to inject an egg, a way of bypassing the problem rather than addressing the man as a person. We've also seen that European pregnancy rates from IVF appear to have reached a peak and may even be declining, and still we're not doing anything to look at the man and to diagnose his problems rather than bypassing them with ICSI. So in order to diagnose the causes and to intervene to correct them, we want to associate certainly ourselves and examine with urologists and people who have the aim of optimizing and improving sperm health. And now I'd like to hand over to Jonathan and let him tell you more about his career and what he has been doing in this area.
Well, Sheena, thank you very much for that very generous introduction. And it was very clever of you to find a picture of me talking in what looked like an Indian restaurant. Perhaps it wasn't a learned lecture, but more an after-dinner speech. So I will do my best to combine the two this evening, because it's always, I think, a great privilege to be able to speak to a mixed audience, by which I mean some healthcare professionals, but also some patients, because as we all know, when we're only talking to our own kind, the talk tends to be along the lines of, look what I've done. And if we're only talking to patients, there's a terrible risk that we might actually oversimplify it. So a mixed audience is, I think, a great boon. So what about this investigation of male fertility? As Sheena has said, the linchpin has always been a semen analysis, but actually everything about fertility involves two people. And so we really do have to think about male fertility in a different way. Of course, sometimes we see men who have no sperm, and clearly then it is a male problem. But actually, short of having no sperm, it is about the degree of the contribution that the male factor may be making. And I've made this point many times about semen analysis. It's a one-off snapshot of what is going on. And of course, even in the time that the audience has been listening to this, most of the men will have made 50 or 100,000 sperms. So this is a dynamic situation, and because it is so dynamic, it must be open to the vagaries of general male health, to all kinds of factors that are out of both the man's control and indeed the doctor's. So we must look at this as part of the problem. But this problem is a big problem. Psychologists have long since described a biopsychosocial mix when disease crosses the line between the psychology of having that disease and the social consequences of having that disease. And I'm quite sure that the comments around this Venn diagram will be familiar both to patients and of course to healthcare professionals. And I think we miss this point, and we often miss the point that one semen analysis can tip a man and therefore his partner, therefore a whole family, into a situation in which the whole issue of fertility is burned onto his hard disk and actually becomes part of the family's screensaver. Now, this is not helped by media. Sheena and I both know the power of the media when we can harness it towards better health, towards better physical health, indeed towards better fertility treatment. But the media is very, very forceful and strident in some of its views. And we have to remember when we're looking after couples and men, the impact of this sort of psychological bombardment. The picture on the right here was I think it was a Sunday Times or Sunday Telegraph cover. And inside that edition was an even more powerful image, I've lost the slide, but of a lady holding a baby under her arm at a crossroads with a road sign that said in one direction, career, and in the opposite direction, 180 degrees away from that family. And this is a conflict that has become ever more prevalent as society has, so say, become more affluent, certainly in monetary terms, but possibly impoverished in terms of starting and enjoying a family. So what is the problem with this semen analysis business? If we think about semen analysis with all those numbers, just like any other investigation, let us say a full blood count. Well, of course, the point about a full blood count is that if you are anemic, and that is about you and your red blood cells. It doesn't predict a probability of anemia, it makes a statement based on numbers. Now, of course, with the semen analysis, it seems to most men, and men do numbers, that this must be set in time, this must be meaningful, this must be diagnostic. It must be above the line or below the line. But of course, it's not like that at all, because actually the numbers on the semen analysis conform to a Gaussian distribution, and merely a probability of fertility is being predicted by those numbers. And this is a difficult concept to get across, particularly when there is often a very casual interpretation of a single semen analysis. We've all come across colleagues, particularly in primary care, who have actually read the normal values for semen analysis as being the patient values, giving the patient an entirely wrong perception of their situation. And often when patients, people, men, couples seek a semen analysis, and it turns out to be towards the lower centiles there, then the conclusion that they come to and that their advisors reinforce is that they will never have a baby. So seldom in medicine does one test, which is not an absolute, which is merely a predictor, seldom does one test have such a profound effect on an individual and his partner, and therefore his extended family. A low sperm count, possibly a man who had a difficult childhood, maybe had to go to ITU as a baby, that problem of his low sperm count will actually, of course, extend, as we all know, to his mother, who will inevitably blame herself for something to do with her son's fertility. So we are very casual as a profession in delivering these results. And sometimes those results, particularly if it is azoospermia, may be as devastating at a point in time as a cancer diagnosis, as received and interpreted by the owner. And then, of course, the owner of that semen analysis, the patient, the man, begins to explore the situation further and rapidly finds out that there has been a decline, a worldwide decline, as we know, in semen analysis over the last 50 years. This has been hinted at by many workers for many years, but it wasn't until Levine fairly recently collated the data that it now becomes clear. This is important, of course, when one is talking to patients, because many of our oligospermic patients are in fact on a spectrum of which this is part. And then one can at least begin to explain what up until that point may be quite inexplicable. So we have a variable commodity, a variable biological fluid, which is not giving us absolute values, which is merely giving us a probability. And often the reason for that low count remains unexplained. So this is the most unsatisfactory psychological situation in medicine, where the result may not be reliable, the result itself may be variable, and we don't have an explanation for that result. If you put that into the context of almost any other medical diagnosis, then in fact you can see how, as Sheena was saying, emasculated and lost a man with a low sperm count might feel. So what actually can we learn? Well, we are all very much aware of the notion of morphology. Morphology is a dangerous thing because most men confronted with 1% morphology will immediately take three conclusions. The first is he'll never have a child. The second is that if he does have a child, that child will be abnormal. And therefore, the third conclusion is that in some way he has let down his partner catastrophically. The total motile sperm count, we'll come on to this later, is perhaps quite a useful prognosticator because it does relate to natural conception and the chance of natural conception, a derivative of the progressively motile sperm and the total number of sperm in the ejaculate. We'll mention a bit about peroxidase positive cells, the effect of inflammation in the genital tract, and how those peroxidase positive cells, those leukocytes, might be adversely affecting sperm quality and particularly DNA. So abstinence is another very important issue. Men feel, ever since the 3-day abstinence rule was set up by the WHO now nearly 60 years ago, they feel that their sperm count will somehow be better if they save it up. And of course, actually, the reverse is probably true. Biologically, not surprisingly, we were designed to ejaculate frequently. We know that sperm are competitive and that procreation to a large extent is opportunistic. And then there's the whole issue of oxidative stress, really terribly important as the absolute mediator of sperm quality as measured by DNA fragmentation. And here is the trouble with morphology. I needn't really go through this. I made the point about the extremely negative psychological effect of this, but we do know that there is an overlap. There isn't a linear relationship between morphology and DNA fragmentation, but there is certainly an overlap there. So this may be a sign that further second-line investigations, and we could argue that DNA fragmentation ought to be a first-line investigation, but certainly when there is persistently poor morphology, we may look to the contents of the sperm rather than merely telling the poor patient that their sperm are abnormal. And again, a relationship between oxidative stress, as I've mentioned, probably the common denominator, the common pathway of DNA damage to sperm. And then this comment about the total motile sperm count. If we've got a total motile sperm count of greater than 20 million, then certainly we perhaps should pay less credence to poor morphology. And so here's some very interesting data, a recent paper, I think it's about 2016, talking about the value of total motile sperm count as a predictor of the likelihood of natural conception. And an even more interesting paper, I think, 1983, which gives away my extreme age here, but it is important because, of course, 1983 was before IVF really got going, and certainly almost 10 years before ICSI started. So this gave the opportunity of actually watching what happened to subfertile couples with time and matching this to sperm count. And we have really developed the notion, not entirely unfairly, that if there have been a year or 18 months without natural conception, and if the sperm count shows an oligospermia, possibly 5-6 million sperm, then the only alternative is IVF or ICSI, probably ICSI. And in order to justify this big step into the unknown for the vulnerable couple, then very casually, doctors will say, well, you're not going to do it any other way. But of course, that isn't true. And the consequence of saying you're not going to do it any other way, once again, feeds back into that biopsychosocial model, and the poor couple may indeed even stop trying naturally, and the whole situation becomes far more upsetting than it need be. So oxidative stress, the relationship between oxidative stress and leukocytospermia, those are the white cells, the peroxidase positive cells. A lot of interest just recently, a very good paper from Agarwal and his colleagues about leukocytospermia, and our attempts in London to try to relate DNA damaged sperm to the presence of oxidative stress measured by different ways, both in the seminal fluid known as the seminal plasma, but also the free radicals that attach themselves to the sperm head. Now, these relationships are inconstant and they are complicated, and I think we're only just beginning to unravel them. But there is certainly something correctable when you can measure high levels of oxidative stress and leukocytes, then there's something going on here. Now, whether these things are derived from the apoptosis or the death of the sperm, creating a self-fulfilling downward spiral of sperm damage, more white cells, more oxidative stress, higher DNA fragmentation, or whether these things are extraneous due to other causes of inflammation, is something I think we have yet to understand fully. But these are very important adjuncts to understanding damaged sperm on the basis of DNA fragmentation. So I think we've covered the issue about semen analysis being diagnostic, particularly when we must accompany this by a physical examination so that we get some feel for where we are. Now, of course, diagnostic it may be when there is azoospermia, but the azoospermia with the normal FSH is really rather more complicated than that, because we may be dealing with a low pH and a low volume, in which case one suspects that there may be an absence of some of the genital tract, particularly the vas, such that there is a disconnection, a congenital disconnection between the testicles and the prostate. But of course, it could be obstruction. And this for obstruction, physical examination is really important, because a man with normal volume testes, with palpable vasa, but big palpable epididymes and a normal FSH and azoospermia has probably got obstruction. And if you're not used to examining patients physically and you don't quite understand what you're doing, then these men can fall into a terrible slough of despond. And had they only been examined first off when the first semen analysis showed azoospermia, one would be able to reassure them that actually it is likely that there may well be sperm within the testes, and actually their conclusion that they're never going to have children is quite wrong. One does have to be careful in certain cases in which there is not obstruction, but there is a normal FSH, there is azoospermia, because some of these men will have a condition known as maturation arrest, which is not obstruction. And similarly, this is a trap for the unwary, because they may be told, oh, well, yes, you know, 2 nice big testicles and a normal FSH, you must be obstructed, but actually they're not. They have a condition that means that there is a failure of meiosis and they may never actually make proper sperm. Physical examination, as I have said and have stressed, I think it is vital for lots of reasons. You can detect hypogonadism. This is, of course, a biochemical and endocrine diagnosis, but it's also a clinical diagnosis. And clinical diagnosis is really important to help the patients to understand. You can tell if a man's been abusing steroids almost the moment he comes in through the room. And he may well be azoospermic. And it's very important to have an appreciation of this. The Office for National Statistics reported 2 years ago that across the board in the UK, between 6 and 7% of men were abusing steroids. That's an awful lot of men, and many of them are young, and of course, they become addicted. I had one patient recently who told me that his dealer in the local gym had turned from cocaine because there was much more profit in steroids, and of course they were legal. So we can also assess the scrotal contents. We can see whether he might have had an operation. Often they've forgotten that they've had an orchidopexy, and there will be a scar in the inguinal region. And we must also make sure that there are no congenital abnormalities that might be associated with oligo and azoospermia, the hypospadias, and of course, a past inguinal hernia. And then we got the question of varicocele. And I think this is important because sometimes one can physically diagnose this, and one is beginning to develop a picture of possible treatment or mitigation of this man's situation. And of course, it is old-fashioned doctoring. We're getting away from old-fashioned doctoring. Zoom is taking it away from us. The telephone is taking it away from us. Many agencies, medical agencies who do blood tests with results online, all kinds of apps. But the old-fashioned laying on of hands has a role. Now, the varicocele. Well, if we go back a long way in time, we repaired all the varicoceles. But there is a consensus developing, and the American Association and the European Association are now including the importance of varicocele and indeed the importance of DNA fragmentation when there are significant varicoceles in their guidelines. NICE still, in the UK, rather resolutely ignores varicocele, or at least refuses to recognize it, or possibly hasn't considered it properly. But I think the comments made below that if one compares the incidence of varicocele with the prevalence of varicocele in those men who are some fertile, then indeed there has to be something in this. There really does. And indeed, I believe, and many more people are now believing that this is true. So before ICSI, what happened? Because one can really only work out the value of an fertility treatment in a man before the majority of people were in fertility units having ICSI as the only possible solution. So before ICSI, 1984, the graph on the left, this was from work done by Hendry at St. Bartholomew's Hospital, the marvelous Bill Hendry, who was my mentor there. And this is comparing fertile men, in this case donors, sperm donors who had been fertile before. So this is comparing the red line, the effect of the use of donor sperm in aged matched women. These women were all under 36 years of age, and it shows the cumulative pregnancy rate in the blue and the green line. And when you look at the blue line, these were men who started off with an oligospermia, and the green line is all comers. So before ICSI, there were a group of us, now very aged like me, who just sort of knew that treating varicoceles was a good thing to do. And more recently, a group of us, including several urologists, my good friends Maj Shabir and Saks Minhas, and Professor Cheryl Homer, have got together to try to indicate the real indications and measurable indications for treating varicocele. So I think we have to just consider a very simple proposition. can you see the varicocele when the man stands up? And the ultrasound in the bottom right-hand corner shows a cross-section between, taken across the scrotum at the level of the upper pole of the testicle. And there you can see the large veins, the black holes as they were, that are actually insulating the testicle. And the blood in those veins, of course, is refluxing from the warm intra-abdominal cavity and will make sure, when it's that size, that the scrotal temperature rises by 3 or 3.5 degrees centigrade. And that then is much too high for spermatogenesis. So the cutoff for vision is about 3 millimeters, but the cutoff for a significant varicocele when associated with raised DNA fragmentation is 2.6 millimeters. And I think that we are all beginning to accept now that this is a leading cause of subfertility and a leading cause of raised DNA fragmentation via, amongst other things, the agency of oxidative stress. So here we come, DNA fragmentation. I think it's very important for opinionated people, and by opinionated, let's define most doctors, myself included, as opinionated, but it's important to make this my opinion rather than some kind of ex cathedra statement. And so the unexplained, I believe, can often be explained by raised DNA fragmentation. And patients want explanations. Doctors, of course, seek explanations, but knowledge, when you are in a desperate situation and you don't know which way to go, and there have been 3 failed cycles of ICSI, knowledge is both comforting and powerful. We've mentioned varicocele, and I at least believe that one should use raised fragmentation, often against a background of unexplained infertility, but often with an oligospermia. One should use DNA fragmentation to assess the relevance of that varicocele, and then one can use a follow-up fragmentation test to measure the efficacy of that treatment. And I think Sheena was showing us one of these slides from a publication of 2 or 3 years ago, which showed that DNA fragmentation measurements were reasonable predictors of ART outcome and therefore of ART failure. And actually across the world, there have been many publications, many from Esteves in Brazil, and also from the large and excellent units in Sydney and Australia, which have come to similar conclusions using, of course, the different methodologies and modalities of measuring DNA fragmentation. But the different modalities do not make them less valid. They might just make them a bit more difficult to compare. And really, this last statement is entirely obvious. We talked about the huge variability in semen analysis, and therefore I think, certainly in my experience, DNA fragmentation is a more reliable and reproducible method of trying to understand whether one's intervention has worked. And this final comment, I think, is very important. We are not entirely clear about the absolute relationship between DNA fragmentation and a failure of meiosis in spermatogenesis. But clearly there is an overlap here. And we know, for example, that the sperm of elderly men, and elderly is not that elderly, certainly over 40, and possibly starting even earlier, are associated with poor fragmentation. And this poor fragmentation may be associated with a cluster of abnormal findings in children. These are not large numbers, but they are enough to reach a degree of significance. And I think that we should be very mindful of this. And it is only by studying different situations, different etiologies, and then perhaps concluding that the DNA damage to the sperm is not associated with any other condition or illness, or transient fever, but is actually an intrinsic phenomenon. It is only by understanding this more that we will be able to understand the relevance of DNA damage to the next generation, and then with time we can begin to give patients clearer and more useful advice. So it's difficult to understand DNA fragmentation because the different tests are measuring different things. And if you don't quite get the whole picture of male infertility and all the various facets of it and other conditions that might be running alongside it, then it becomes even more difficult to understand. Because once again, a bit like the semen analysis, it is not an absolute. It is referring, remember the bell curve with the different semen analyses and centiles. It is a little bit like that, because you have to look at it in the context of the couple. Because of course, young eggs may repair some of the DNA damaged sperm. And thus, it is not the case that abnormal DNA fragmentation is almost ever associated with absolute infertility. And then, of course, in order to make this real in clinical practice, you have to actually believe that it's relevant. And one of the things that is happening that is bringing second-line tests into disrepute is that the patients are asking for the second-line tests, and then the people who have been forced, the doctors who've been forced to do it because, you know, it's out there, are not able to explain it. And sometimes that's because they don't actually believe it themselves. And therefore, we've done a test that we now can't explain, that isn't useful, and this actually compounds the problem of lack of knowledge and, as Sheena mentioned, emasculation. And then you have to have some view about what you do when you find it. And that, I think, is something, again, the treatment, the improvements, certainly the varicocele and other conditions, particularly genital tract infections and inflammations. If you're going to do it and you find that it's abnormal, you then have to understand what it might be due to and actually treat it. And this last comment is entirely understandable, and I don't say this with any rancor, and I don't say it with any malevolence at all, because if you are in a fertility unit, then you have to just work with the material you've got, and what you've got are sperm and eggs and many and increasing devices that might help to select the less DNA damaged sperm. And some of these are quite fascinating in their construction and in their design and in their conception. So I don't, for one moment, suggest that these are wrong-minded. It is just that if we believe, and new innovations, we do tend to believe for 5 years until we prove that they perhaps weren't as good as we thought they were. If we believe that we must do the best for the couple, and all we have are eggs, sperm, and a microfluidic chamber, for example, or a high-powered microscope, an IMSI microscope, then it is only human nature that dictates that we will do whatever we can in that couple's best interest. But in so doing, we may be negating or ignoring the fact that there is a broader treatment protocol or considerations that may be affecting the whole man, the whole individual, and not just his sperm. So I think we can make a few quite sensible and non-contentious conclusions here. And there's no need to reiterate these in voice. Here they are. And I think that last comment in my practice is really important. And if there was one picture that the audience could take home with them, I would choose that bio-psycho-social model. And if we keep that in our minds, I think we may be more careful with the words that we use. So we like the notion of physical examination. And not just because we discover things, but because it is the old-fashioned laying on of hands and looking after people. And we believe in second-line investigations, and we absolutely believe in treatment. But this, I think, has been the trouble with many areas of medicine, many areas. And we now are almost obsessed, and in many ways quite rightly, with an evidence base. But if ever there was a subject that it is almost impossible to get an evidence base about, it is couple fertility, because this is about the couple. This is about the quality of eggs as much as the quality of sperm, the age of the two people, and their circumstances. So to get evidence, level 1 evidence that counts, is really difficult. I think Sheena would probably agree. This is almost a lifetime's work to get a chink of real evidence in this particular subject. And therefore, let us try to make it better, but acknowledge that we cannot, with our state of present knowledge, actually make it perfect. And finally, though I am no protagonist of the person in the next slide, he does have an uncanny way of getting at the truth with very simple, straightforward statements. And probably that look of despondency says it all for some of our men with an abnormal semen analysis. Thank you very much.
Thank you, Jonathan. You did not disappoint. Yes, we have a number of questions here, and I think we should probably go straight to them and ask you for your answers. First question is, does 48% DFI by SCASA mean that it can cause recurrent miscarriage?
So this is 48% by an SCSA, the DNA fragmentation index rather than the average fragmentation. So I think that the answer must be yes. That is a very high fragmentation index as measured by that methodology, and may actually translate to a higher level when measured by other methods. But I think we would all agree that this may well have something to do with recurrent, particularly early pregnancy loss.
Okay, well, the next relates to this as well, and it's asking, is the examine test the same as the SCASA test? And I'll let you answer that as to how you use the two tests.
Okay, so the important thing to say about the SCSA, developed by our friend Don Evanson many years ago, is that it has been extremely well validated in many tens of thousands of men. And though the performance of this test may be technically difficult, nonetheless, I think that when it is being done in proper controlled circumstances, it is very reliable. However, it tends to give very broad categories of sperm quality. And at the top end and at the bottom end of the DFI measurements, I think that it is highly discriminatory. But in the middle, it might not be quite so discriminatory. But I think nonetheless, this is a useful and proper test. And I would say that for clinicians, the main thing is to get used to a test, to understand it and its validity clinically, to do the other second line investigations so that you can get a feel for what this means. Never forget the lady's age and never forget their history. It has to be put into context. So I happen to use the COMET test, the gel electrophoresis test, examines test more frequently than the SCASA, but I grew up with SCSA, and indeed some of the very early research that James Nikopoulos and I did was all about SCSA, sperm aneuploidy, and failed IVF and ICSI. So I wouldn't challenge its validity at all. I think it is a matter of getting used to a particular test and understanding it.
Okay, okay. Now the same questioner is wondering, if you had 48% DNA fragmentation, what abstinence time would you recommend? Would you recommend a shorter abstinence time than WHO?
Absolutely. So I would first of all make sure that if this is a very severe oligospermia or a cryptospermia, I would make sure that with 12, 18 hours abstinence, the embryology laboratory wouldn't throw their hands up in horror and say, but there aren't any sperm. But actually that is seldom the case. And it is even the case that when you've got a severe crypto, the second ejaculation on the same morning may actually produce just as many sperm or more. So in general terms, shortening the period of abstinence is important. But I think if you're going to advise your patients to do that, then you do need to have a little conversation with your friends in the embryology lab, just to tell them what you're doing and why. And to begin with, you may have to actually demonstrate that these short periods of abstinence are perfectly tolerable in terms of finding enough motile sperm for ICSI.
Okay, that's great. Now here's another question, and this is for asking about your thoughts on microfluidic sperm selection before ICSI, if you had a patient who had raised DNA fragmentation.
Sure. So this is a fascinating subject, because it is based upon the extraordinary ability of sperm to find their way through a maze, or to bounce off little man-made hurdles for them in the microfluidic chambers. It's a sort of demonstration. The word, and I mustn't go too far because I don't really understand physics, is rheotaxis. Of course, sperm do chemotaxis too, but the microfluidic chamber aims to get sperm of better quality. Those will be the most motile sperm on the other side of the assault force. So it's a very simple principle. And if you look at animal sperm, then it does that extremely well. But animal sperm is much better than human sperm. Human sperm has got an awful lot of non-contributory elements in it. And it's not, in inverted commas, as good as many animal sperm samples. So I think one has to be careful, because if you have poor quality sperm, it might not get through the chamber. And Sheena actually has done a lot of work on how DNA deteriorates in tired sperm, in older sperm. So my only worry about microfluidics is we do actually have to be sure that we are achieving what we set out to do. But I think we ought to make sure that we're not actually sometimes doing the reverse.
Causing more problems. Okay, here's another one. Fantastic talk as ever. What is the evidence so far for improved live births after varicocele repair?
Of improved live birth?
Yes.
Okay. So
increased live birth rates, presumably.
Okay, so this could be the beginning of a homily. So, or a polemic. I don't know who's asked the question, but the original data from Bill Hendry at Barts in London, I think, was extremely compelling. And in those days, in the early 80s, we would surgically repair Palomo approach, suprainguinal, 3 or 4 varicoceles on various operating lists a week. So that data that I showed you with the green line, the red line, and the blue line, I believe to be utterly compelling. Now, if we then move on to the early 2000s, we have a flawed meta-analysis. And I think that we didn't understand. The urologists thought, oh, crikey, meta-analysis, all that means is that you bunch a load of papers together. So instead of looking at 37 patients, you're looking at 3,700. This is wonderful, said the urologists who weren't scientists. This must be true. But of course, what we hadn't understood, and what only those of us who tried to do it now do understand, is that the systematic review that must precede the meta-analysis was fundamentally flawed. And therefore, we were not comparing like with like. If you picked out the 5 or 6 papers that were a bit homogeneous from that meta-analysis, what you actually found was that if you were dealing with women under 36, I think it was, then the cumulative pregnancy rate at 6 or 7 months in those patients was about high 30s%. So actually not dissimilar from that you might achieve live birth rate in ICSI or IVF in the same group of women. And I think that comment fits very nicely with the old data that I showed you from 1984. Now, at the moment, our friend Ashok Agarwal is running a global varicocele project.
Yeah.
And he has got literally hundreds of urologists involved in this. Mm-hmm. He's got teams of mm-hmm. clever people with clever team leaders doing the systematic review and looking at the papers and getting them retranslated by people who actually understand the words, which is another problem of meta-analysis and systematic review, because what people have done in the past is that they just looked at the English or whatever it is translation of the abstract and taken that data, or even the data from the conclusion, because they haven't translated the whole thing. And they don't understand the whole thing. So I think that Ashok's work is going to show that meta-analysis of the early 2000s was flawed, and that there is a real purpose in repairing clinically visible, measurable by ultrasound varicoceles, particularly when there's raised DNA fragmentation and no other cause.
Yeah, great. Now here's another question, and this moves away from surgical interventions, and this I think is possibly a patient who says, if you had an examined result of 35%, would you expect to see a reduction with treatment of a purely holistic approach of exercise, better lifestyle, vitamin supplements?
The answer is usually yes. Usually yes. It's a very, of course, like everything else, it all depends where you started. So it all depends how you started. I mean, I am reminded of a patient I saw 2 weeks ago, and he sat in front of me, he said, I've radically reduced, he said, my alcohol, my lifestyle is completely different. So of course, the next question is, well, how much did you drink? To which he replied, far, far too much. So then the next question obviously is, well, how much is it now? To which he replied, far, far too little. So the answer to your question is, it does depend where you start, but I do embrace the lifestyle changes. I think that why shouldn't it be that obesity with all those cytokines has the same effect on male fertility as it does on female fertility? I mean, why should there be this huge biological difference? And I think we're just beginning to explore this, but getting evidence for the statement I've just made is almost impossible, because in certain parts of the world, a very obese man will nearly always have, in the fertility unit, a very slim partner. If you go to other parts of the world, then the obesity is almost contagious. So where one is obese, the other is obese. So getting the evidence in a sufficient number of people for these statements is extraordinarily difficult.
Oh, it's so difficult to do any of these with human beings because there are so many variables. So I think we're nearly at the end of our questions, but there's one more, and this is, what would you recommend for a man who had no vas?
Oh, so congenital absence of the vas. This is not amenable to, sadly, to reconstructive surgery. Now, the good thing about this condition is that it is clear. It is explicit. We have a diagnosis. We have absolute understanding of what is happening here. And the vast majority of men with this condition do have sperm that is relatively easy to retrieve, and mostly that sperm is of good quality. Now, the other fascinating thing about this clinically is that most men presenting with absence of the vas present early, and the vast majority have therefore young partners. Now, this is a really interesting thing psychologically. You may say, do they have these men? Is there an inkling that there might be something wrong and they present sooner rather than later? And there may be, but the combination of the probability of good quality sperm and the probability of a relatively young partner gives, I would say, an optimistic outlook, but it does require surgical sperm retrieval.
Yes. And you alluded at one stage to surgical sperm retrievals to beware. I wonder if you could just summarize on when you would think a surgical sperm retrieval was suitable and how you would approach that.
Are we talking about azoospermia?
Yes.
Or
Well,
non-obstructive or obstructive, Sheena?
Okay. Let's go for obstructive. That's easy.
Okay. So the important thing about obstructive, several important. The first important thing is obstructive azoospermia, you're going to find sperm. The next question is, if you're going to find sperm, will it be as good frozen or fresh? And the evidence, such as it is, says that frozen sperm, which is taken from the epididymis, which is usually the site of obstruction, is as good as fresh, because the sperm's gone through its finishing school, it's got its motility, and although you'll lose half of them when you thaw them, nonetheless, what you've got left should work fine. That's not exclusively the case, but it's a good starting point. So a surgical sperm retrieval, obstructive azoospermia, the way forward. And the other reason, the other clear statement is that occasionally one is able to reconstruct by doing an epididymovasostomy or attaching the vas to the epididymis. Now, this, of course, is what everybody wants, because all men want to be normal and they don't want to go to a fertility unit. It's a difficult operation, a very enjoyable operation. We like doing it. That, of course, doesn't make it more successful.
Yeah.
It might make it more attractive for various reasons, but not successful. So let's get the sperm in the obstructive azoospermia. Let's freeze it. Let's take plenty of it. And we do have the opportunity when we're there, just possibly for a reconstruction.
Fantastic. Okay, I think that's pretty much it. So I'll hand back to Eileen.
Thank you, Jonathan. Thank you, Sheena. I think there was a lot of questions there. So thanks everyone for their input. And just before we go, just to remind you what's coming up in the series as well. So next month, we're joined by Francisco Mora of ARIA Fertility, who will be talking about the male fertility assessment and integrating information to manage male infertility in the lab. In October, then, we are joined by Sandra Esteves from Brazil, a board-certified urologist and consultant in assisted reproduction. And he will be discussing using surgically removed sperm and fertility treatments. And then we have 2 webinars in November, one at the start where we're joined by Professor Peter Humiden from Skeevy, a specialist in reproductive endocrinology and professor at the Fertility Clinic in Skeevy Regional Hospital, Aarhus, in the University of Denmark, and honorary professor at Odense University. And he will be joining us to discuss the links between lifestyle and sperm DNA fragmentation. And then our final event at the end of November, for the year, we will be joined by Professor Andrea Salonia, who is professor of urology at University of Vita Salute San Rafael and the director of Urological Research Institute at the IRCSS Ospedale San Rafael in Italy. And he will be discussing, is infection a common cause for male fertility? So if you haven't already registered, please do so on the events page on our website. And we look forward to seeing you at the next events. So it just leaves me to say thank you again to Mr. Jonathan Ramsay and to Professor Sheena Lewis. Thank you all for joining us this evening. Don't hesitate to reach out if you have any questions. We look forward to seeing you at the next event in September. And also, I know we have a lot of questions just about the recording to share with your friends, your colleagues. So give us a little bit of time. That will be online, hopefully tomorrow morning, on the website, and we'll circulate that through a link as well for all of our registrations as well. So thank you all for taking time out of your evening. Enjoy the rest of your evening, and we look forward to seeing you next time.